All right, today we are diving into something truly revolutionary in the world of surgery. It's a field where incredible, complex operations are done deep inside the body, from the inside out, without making a single cut on a patient's skin. So let's just start with that central question, because it's a big one. How on earth can you perform a precise surgical procedure on a muscle, let's say, buried in the wall of the esophagus, without ever using a scalpel on the outside? No visible scars. It honestly sounds a little like science fiction, but I promise you, it's very real.
And the answer? Well, it's just so clever. Instead of the traditional approach of cutting through skin and layers of tissue to reach a target, surgeons are now using the body's own natural highway, the GI tract, as a kind of secret surgical corridor to get the job done.
Now, to really wrap your head around how this hidden corridor works, we have to define the place where all this magic happens. We need to talk about the third space.
Okay, so think of the wall of your GI tract, like your esophagus or stomach, as having different layers. The first space is the inside, the lumen, where food passes through. The second space is way on the outside, in the abdominal cavity. But the third space, and this is the key to everything, is the submucosa. It's this potential space sandwiched right between the inner lining and the outer muscle. The analogy here is perfect. It's like you're tunneling between the layers of drywall in a house to fix the wiring inside, all without ever leaving a mark on the painted surface.
Now, this idea didn't just appear out of thin air. It was a really careful step-by-step evolution. Back in the 90s, endoscopists got really good at working in that submucosal space with a technique called ESD. Then, in the early 2000s, another concept called NOTES tried to go even further, but, it ran into some challenges, especially with closing up the entry point securely. The real breakthrough, the moment everything clicked, was in 2008 with the very first POEM procedure. It perfected this method of getting in, doing the work, and then sealing that third space up tight.
And that brings us to the procedure that really proved how powerful this whole concept was. We have to talk about POEM. It was an absolute game changer. So what was the big problem POEM was designed to solve? It's a really tough condition for patients called achalasia. Basically, the muscle at the very bottom of the esophagus, the lower esophageal sphincter, it just forgets how to relax. This creates a blockage, making it incredibly difficult, sometimes impossible, for people to swallow food.
The real beauty of POEM is how elegant it is. It's really just 4 main steps. First, the endoscopist makes a tiny entry point in the esophagus lining. Second, they create that tunnel, burrowing down through the third space until they get right to that tight sphincter muscle. Third, they do the myotomy, a very precise cut of that inner muscle, which instantly relieves the pressure. And finally, they just go back up the tunnel and seal the entry point with a few clips. The GI tract is whole again, and there's absolutely no scar on the outside. It's incredible.
And the results? Well, they speak for themselves. We're talking a long-term clinical success rate of over 90%, and that's based on multiple studies, some with follow-up as long as 10 years. So this isn't just some novelty act, it is incredibly effective.
So the big question is, how does this stack up against the old gold standard, the laparoscopic Heller myotomy? Well, what's amazing is that the clinical success rates are pretty much the same. The huge win for POEM, of course, is no external incisions. Now, there is a trade-off. POEM does have a higher rate of post-op acid reflux because the procedure can affect the body's natural anti-reflux barrier, and that's a really key discussion point for doctors and their patients.
But here's what's so exciting. POEM isn't just a one-trick pony for achalasia, it's a platform technology. That core idea of tunneling has been adapted to create a whole family of new procedures.
You can see the versatility right here. The original POEM, which we now sometimes call e-POEM, targets the esophagus for achalasia. But look, just by changing the target, you can treat totally different problems. G-POEM goes after the pyloric sphincter for gastroparesis, and Z-POEM targets the cricopharyngeal muscle for Zinker's diverticulum. It's the same fundamental concept, just applied in a new spot.
Let's take a quick look at G-POEM. This one is for patients with gastroparesis, a condition where the stomach just empties way too slowly, often after medications have failed. The idea is to perform that same kind of myotomy, but this time on the pylorus, the muscle controlling the stomach's exit, to help food pass through more easily.
And does it work? Well, the data from this randomized, sham-controlled trial is pretty telling. At 6 months, 71% of patients who got the real G-POEM procedure had treatment success. Compare that to just 22% in the group that got a sham or placebo procedure. That's a massive difference and a really powerful demonstration of its benefit.
Okay, so up to this point, we've only talked about cutting muscle. But what if you could use that same tunnel to remove tissue? This brings us to our next amazing application, STIR, or tunneling for tumors. STETR stands for submucosal tunneling endoscopic resection. The principle is exactly what we've been talking about. You make an entry point, you create a tunnel through the third space. But instead of cutting a muscle, the goal here is to find a tumor that's growing inside the wall of the GI tract, carefully dissect it out, and then pull it right out through the tunnel.
And the outcomes for STIR are, frankly, remarkable. A huge meta-analysis looking at over 1,000 patients found a complete resection rate of 98%, 98, and an en-bloc or single-piece resection rate of 95%. This makes STIR a really formidable, minimally invasive alternative to what would otherwise be major surgery for a lot of these tumors.
So let's pull all of this together. What are the big takeaways from this whole revolution in what we call intramural, or within-the-wall, endoscopy? And what's next? You know, this quote from the literature really just says it all perfectly. These procedures are fundamentally changing the game, offering patients incredibly effective treatments that are just so much less invasive than the big surgical operations of the past. It is a true paradigm shift. And for those of you in training, this is so relevant. First, you just have to know this exists. It's a powerful alternative for your future patients. Second, you have to recognize it's a platform technology. The things we've talked about today are probably just the beginning. Third, these are not easy procedures. They require dedicated, highly specialized training to master. And finally, and maybe this is the most important part, it represents a completely new way to think about the problem of surgical access itself.
Which leaves us with this one last, really fascinating question to think about. We've seen surgeons tunnel through the GI tract to operate on muscles and take out tumors. As this technology and our skills continue to get better and better, what part of the body will we be able to reach next from the inside out? The possibilities are really, really exciting to think about.